Welcome, everybody. I know people are going to keep joining, which is great. But we're very fortunate with the Brain Aneurysm Foundation to have another webinar to present to you. And this is kind of great on September 30th, the last day of Brain Aneurysm Awareness Month. So I just want to say thank you to everybody who is joining. But tonight we have kind of a combo webinar. It's brain aneurysms and polycystic kidney disease and what you need to know. I think it's a very important topic for both diseases and then how they intersect. And the people who will be presenting are both from the Medical University of South Carolina, Dr. Joshua Lipschitz and Dr. Kimberly Kuklinski. And they are fabulous and they both know what they're doing and have touched so many patients.
I wanted to welcome everybody to our webinar today entitled Brain Aneurysm and Polycystic Kidney Disease. I want to especially thank the Brain Aneurysm Foundation for supporting and helping us with this tonight and recording it as well as the National Kidney Foundation, our other collaborator. We're both at the Medical University of South Carolina, which is a large tertiary care academic medical center in Charleston, South Carolina, although MUSC actually has 16 regional hospitals throughout the state and growing. Could I have the next slide, please?
Yep.
So in November of 2022, MUSC was designated a PKD Center of Excellence by the PKD Foundation. So this was the original cohort. They're now actually up to 39 centers of excellence. So I'm the director of the MUSC PKD Foundation Center of Excellence, as well as the Renal Division Director here at MUSC. And my lab has been working on polycystic kidney disease for 25 years. And I see patients in clinic with polycystic kidney disease. One of the most feared complications is aneurysms, which is what we're going to talk about tonight. And Dr. Kimberly Kuklinski is part of our Center of Excellence, is a great part of it. And I just want to give her a proper introduction. She hails from Pittsburgh, Pennsylvania. She's a board-certified neurosurgeon. She obtained her undergraduate degree at Carnegie Mellon University in chemistry and psychology, her MD from Penn State College of Medicine. She went on to complete her neurosurgical residency training at the University of Alabama at Birmingham, UAB, where she was twice named the Resident of the Year. During residency, she completed a Master's of Science in Public Health with a focus on epidemiology from UAB. Then she spent 2 years in Boston at Harvard Medical School and Beth Israel Deaconess Medical Center, where she did a specialized fellowship in open and endovascular cerebrovascular neurosurgery, and during that time was a clinical instructor at the Harvard Medical School. After joining MUSC in 2019, she has been voted Faculty of the Year by the MUSC Neurosurgery Residents in 2021. And again in 2023, she's published 29 papers. She's been invited to present her research at national meetings and serves in multiple positions within organized neurosurgery. Her research interests are in blood vessel disorders of the nervous system, resident education, patient-physician communication during critical situations, and luckily for us, ADPKD. And so it's a great pleasure for me to introduce Dr. Kimberly Kuklinski to tell us about aneurysms and polycystic kidney disease. Thank you.
Thanks so much, Josh, for that great introduction. I'm going to try to share my slides. Can you guys see those slides now? Thumbs up?
Yeah.
All right. Thank you so much. Yes, I'm Kimberly Kuklinski. I'm an associate professor in neurosurgery. And here's what, so first, let me just say thank you so much. Hold on, let's go back to the Brain Aneurysm Foundation for hosting us with this, as well as the National Kidney Foundation. What is so special to me about this and to finish out Brain Aneurysm Awareness Month is that as many of you who have had ruptures or dealt with the medical field, sometimes we're really good at what we do, but we're a little bit siloed. And this happens to be an issue that really crosses across two specific specialties. So Dr. Lipschitz is a kidney nephrologist. I'm a neurosurgeon. We don't always talk to each other until we started to, in the last 6 months, we really got to know each other and talk about how these patients we share, we can take the best care of, how we can get them to the right place. So I really am so thankful that these two organizations are helping us and letting us reach out to people from both sides to let them understand how this intersection happens and what they need to know. All right, so we have a lot to tackle tonight. I know people are with us tonight from the kidney side, from the brain side. Some of this may be redundant for you. I just want to make sure that everybody in the room kind of has a working knowledge of what we're talking about and what, I want to convince you of why I think screening is important. And we'll have a lot of time for questions. So we'll start with what is a brain aneurysm? Why is it dangerous to have one? Who's likely to develop them? How we can treat them? And then what is polycystic kidney disease? How brain aneurysms play into polycystic kidney disease, what our suggestions are for screening, talk about a case to kind of bring it all home of why this is important of a real patient of mine, and have a chance for questions. But again, kind of a brief overview for people that aren't as familiar, but then we're really gonna focus on the brain aneurysms and polycystic kidney overlap. So first, what is a brain aneurysm? So it's a blister in the blood vessel. It commonly can happen at a branch point where the blood comes up and switches direction or a curve. They don't cause any symptoms. They're not something routinely screened for. So most patients have no reason to know they have one. But why is it important to know if you have one, or what's the risk of having one? Is that it can bleed. So that's called a subarachnoid hemorrhage or a ruptured aneurysm. And how would you know if this happened to you? Most people describe the worst headache they've ever had. Sudden thunderclap, out of nowhere, the worst they've ever described. When I have patients that know they have aneurysms, I say, if you can ask, is this your aneurysm? It isn't, because you will know it is very different than anything you've had before. Or sometimes people are found down. Now, it's worth saying that about 20% of patients who have a ruptured aneurysm don't survive. So it's important to know you have one because there are risks that come with it. And of the patients that make it that have a rupture, about half of them require assistance to walk or worse. So a lot of people have great outcomes. Most people are not 100% the same as they were before the day that happened. And some of them have really terrible disability or can even pass away. So it's important as far as a public health problem for us to understand that. Now, the risk of rupture is pretty low, but the consequences of a rupture can be a big deal, which is why we sometimes talk about, how do we prevent this bleeding from happening? So what are some risk factors for aneurysm development? We know they're more common in women, people who smoke, people with high blood pressure, and people with a family history. Those are the ones I often mention to patients. I take care of lots of patients who don't have those risk factors, who still go on to have aneurysms, but we know these groups have an increased risk than the average. And so if they don't cause any symptoms before they bleed, the vast majority of them, how do people find their way to me to have an aneurysm fixed? Well, it might be because they've had a bleed, unfortunately, but a lot of people that I'll see tomorrow in my clinic come because they've had imaging for some other reason. They've had a head injury or a stroke workup for vertigo or headaches. They get a CT scan with vessel imaging like a CTA, and it's identified on that. And that's an unruptured aneurysm. Or sometimes for family history screening, they might have imaging and find out they have an aneurysm and then find their way to someone like myself to talk about that and what their options are. So because it's such a big deal to have a rupture, sometimes we treat them preemptively. We go to extreme lengths of even doing surgery. Great illustrations from the BAF on ways to fix aneurysms. So you can do a surgery where you open up an incision and a window of bone in the operating room, go to where that aneurysm is and put a metal clip or clothespin across the base of it. And so blood can't get in that pouch, so it's not at risk for bleeding. Sometimes we go in from the inside, like a heart cath, and snake small catheters up from the wrist or the groin, all the way up into the head. We can deliver small coils, metal springs into that aneurysm. And that is kind of like stuffing a sock in that metal pouch, stuffing a sock in that pouch. So fresh blood can't get into there because the coils occupy that space. I like to tell patients it's like filling their dining room with balloons. So it's still there, but you can't use it because functionally it's occupied by this other stuff. So the point there is just to say there are ways to fix aneurysms. The reason to fix it is to either prevent a rupture if you haven't had one, or if you have had a rupture, to prevent a second rupture, which could be another catastrophic event. So there are ways to fix them. And not everybody needs a preemptive fix. There's plenty of people that I observe. That's why someone with expertise in this can help guide you on what needs to be fixed and what doesn't. Sometimes there's risk on all paths. If you have an aneurysm, there's risk to treatment, there's risk to leaving it alone, and us kind of balancing that is how we decide who we suggest treatment for. So now we're going to switch directions a little and talk about polycystic kidney disease. I'm going to do my best, and hopefully Dr. Lipschitz can keep me honest and pipe up if I say anything amiss. So what is this? So it's a genetic disease that happens about anywhere from 1 in 400 to 1 in 1,000 people. And it is a genetic disease. The most common form is autosomal dominant, which means if you have it, your kids each have about a 50% chance of going on to develop it as well. And it's a defective gene in this vascular smooth muscle membrane of the cells. And what happens is you form these cysts. They can happen in the liver, the pancreas, other places, but primarily the kidney is the concern. These cysts are filled with fluid. It's not functional tissue. It doesn't work. And sometimes these fluid cysts can get so large, they press on the good kidney function and kind of block out the good kidney from being able to work because the kidney is overcome by these cysts. So it can cause patients to that have it, they get these very large kidneys, if you look at the normal versus this. So patients can develop high blood pressure. They can even need to go on to dialysis as their kidney function worsens, and sometimes even need a kidney transplant. Okay, so now what about brain aneurysms and polycystic kidney disease? So if we look at the numbers, in the general population, about 2 to 3% of people have an aneurysm. If you just take all comers and we screened everybody with a scan. If you have polycystic kidney disease, about 12.9% of those patients are going to have an aneurysm. So a significant increase over the general population. Now, what if you have polycystic kidney disease and someone in your family had an aneurysm? Doesn't even have had to rupture, but they have an aneurysm. Then it's as high as 17%. So that is really high as far as the things I take care of. So what got me interested in this topic is I see lots of patients that come in and they had no reason to know or be screened. But this is a population where we know that screening makes sense. Screening to prevent a rupture that can be disabling or deadly. So how do we make sure people know that they should be screened and how often they should be screened and things like that? So that's what we're going to talk a little bit more about. So number one, if you have PKD, you're more likely to have an aneurysm in your brain. You can develop aneurysms in other vessels. I am talking strictly about brain aneurysms. You don't want me talking about other kinds. Okay, so what else? If you have a brain aneurysm and you have polycystic kidney disease, not only are you more likely to have one, but the rupture risk is about 5 times what the general population has. So not only are you more likely to have it, but if you have it, it's more dangerous than the average. There's also literature and research that shows that they even rupture at a smaller size than in the general population. And not only that, but if you have polycystic kidney disease, the average age of a rupture for polycystic kidney disease with an aneurysm is 41. In the general population, it's 55 or older, depending on where you live and what the lifestyle factors are. But so younger patients, and for patients with aneurysm bleeds with polycystic kidney disease, about 10% of them are under 21. And I will tell you, having done this for 15 years, people under 21 don't come in with aneurysms. That is not typical. If that happens, even people in their late 20s, early 30s, flags are going off, bells are going off in my head. We got to look for something more because this is not the typical patient that develops an aneurysm. So patients with polycystic kidney disease can develop high blood pressure because of their kidney troubles. But they can develop aneurysms even before the high blood pressure develops. So that can, sometimes the high blood pressure can be one of the first tip-offs that initiates a screening where they end up finding out they have polycystic kidney disease. And certainly we know high blood pressure influences aneurysm formation and rupture. So now you have somebody who already has weak vessels, now has high blood pressure. It sort of accelerates this whole process potentially. But the aneurysms can form even independent of the high blood pressure. So kind of high blood pressure aside, the risk is still high. It's not just because the blood pressure is high, but now we've got two forces that are not great for this population. So just to kind of recap, this is what I want kind of the take home to be. If you have polycystic kidney disease, you are more likely to have an aneurysm. If you have an aneurysm, you're more likely for it to bleed. And it's more likely for you to bleed at a younger age than the average. So that's scary. What can we do about it? So I think it's KDIGO. Did I say it right? KDIGO.
Yeah.
Okay, KDIGO is the Kidney Disease Improving Global Outcomes Organization, and they publish these very comprehensive, very helpful guidelines about kidney disease, where experts come together and say, these are the guidelines. If you have this problem, this is what you should do. So they do make a recommendation that patients with autosomal dominant polycystic kidney disease, if they've had subarachnoid hemorrhage, they've had a family member that had an aneurysm, or someone that had unexplained death, they should be screened. That is the strongest evidence they kind of have. They have other practice suggestions about, okay, if you have polycystic kidney disease, but you don't have that higher risk situation of also aneurysms within that sort of subtype of your family, they still suggest discussing and considering and offering screening, but they're a little less strongly worded, mostly because I think the research, just the numbers are a little bit lower, and the research, these are small numbers of people that we're talking about. So there's not a lot of research that says definitively, more compelling reasons to screen. Anything on there, Josh, that you want to add?
Yeah, I think our practice now is, it used to be that we had to do angiograms with the contrast and everything, but now we can do without any contrast, the MRAs, which at the time of flight, so you don't even have to inject anything. So the risk is much less. So we're screening everybody with polycystic kidney disease.
Yes. And so, and what I will say is a lot of these patients come to the attention of someone like me because they get to the point where they're ready for a transplant. And that is one of the guidelines from the KDIGO, where if you're at the point to consider a transplant, you should be screened, because before we give you this kidney, we should make sure that you're not going to, have an aneurysm, and we can treat that or address it potentially beforehand. And so that's definitely a checkbox, and a lot of patients get to us because they have a screening at that point. That does present some challenges for us sometimes, because some of the ways I might fix your aneurysm might involve contrast dye. The best way to fix it might be with those catheters where there's contrast dye, or I might need to put you on blood thinners because I got to use stents for 3 or 6 months. And if you're right up against trying to get a transplant, that can sometimes come into the discussion and make our treatments decisions a little bit more complicated. Not to mention that someone could have a rupture prior to that. So again, we're a center of excellence. I love working with people like Dr. Lipschitz that get the patients to me. What we're hoping with this webinar is to get to the patients themselves to advocate, as well as providers who may not work at a center of excellence, who may do some polycystic kidney disease, but they cover all kinds of kidney disease, and they may not know these very niche specific recommendations. I know when we met earlier with our MUSC group, they talked about a time where it wasn't even recommended to screen for the polycystic kidney disease at all because there wasn't treatment. So they said, well, just see what happens for people. But there are some treatments now. And so there's reason also from my perspective, the intersection with aneurysms, to kind of know your status. There are downsides to knowing your status, but I think for me, knowledge is power, and the chance to save a life with aneurysm intervention is part of that discussion for me. Okay, so as we kind of hinted at, what would we suggest for screening? So you can get an MRA, usually ordered by your primary care physician. And we would probably suggest, the guidelines in my personal practice is every 5 to 10 years, you should get a screen. And, I'd probably start at like age 18 or so. That's what I recommend for most of my patients who have a family history or have something like this in their families. And one other thing to note is it's not just, oh, I had my aneurysm screening, I got my aneurysm fixed, and now I'm done. If you have polycystic kidney disease, there's literature that following those patients after they've had a treatment for 15 years, about 25% developed another aneurysm. So if you're in that higher risk group that already has polycystic kidney and forms brain aneurysms, that is sort of an unheard of rate. I will tell you, all the other patients I follow, it's 1 or 2% maybe that develop a second aneurysm or third or something like that. But this is definitely a different beast. So it's something you shouldn't forget about. It's something that if you have a screen and you have a treatment, you shouldn't lose track of someone like me. If you move around, there's people that do this work everywhere. Just making sure that you're getting continually to get screened, because you don't want to miss another one where there's an opportunity to intervene. Maybe a little bit on the good news is if you have PKD, you get an MRA and it's negative, you don't see any aneurysms on it, about 2 to 3% of those patients over 10 years went on to develop an aneurysm. And those numbers are actually pretty similar to the general population. So, you know, if you have a negative screen, you're not out of the woods, but definitely probably puts you in a lower risk category than people that do find something or have other people in their family with aneurysms. So I got to go to the Polycystic Kidney Disease walk in Charleston a few weeks ago and got a chance to chat with some patients and share some of this information. And I heard someone say, well, I've had my transplant, so I don't need to worry about brain aneurysms anymore. So for a lot of patients with polycystic kidney disease, that's the majority of their interaction with this disease is about the kidney. And when they get their kidney replaced, that's a new kidney that works well. They worry about the transplant situation, but maybe not the other things that come along with it. And so I looked this up because I was like, that doesn't sound right to me. There's not really any literature on this, but I would say the brain aneurysms form because your genes that you inherit from your mom and dad have this irregularity and makes your vessels more elastic and more bubbly. And that doesn't change with a kidney transplant. So you don't get a brain vessel transplant at the same time. So I would caution you that my opinion is if you've had a transplant, you still need to be vigilant about this, because your risk factor for forming the aneurysms isn't just the bum kidney, if you want to say. It is the genes that you have that cause that, and you still have those even with a fresh kidney. Dr. Lipschitz, would you have any comments on that?
Yeah, that's absolutely. So even though they call it autosomal dominant polycystic kidney disease, it's really a systemic disease where you have liver cysts and pancreatic cysts. And we don't know exactly why the patients are getting aneurysms in the brain, but when you get a kidney transplant, you still have the gene mutation in all the cells in the brain as well as everywhere else in the body. So absolutely, it doesn't take away your risk for an aneurysm with a transplant.
So even if one person recognizes that and gets screened, this will have all been worth it. All right, so just one last case to bring it home, and then we'll have a chance to interact a bit and answer some questions. This patient allowed me to discuss this with his permission. He said, if this helps anybody, tell all you want. So this was a 22-year-old guy who was in the military and was doing push-ups. They had a really strenuous workout. He stood up and passed out, had really bad headache, nausea, vomiting. He and his friends thought, hey, it was a bad PT, kind of rest. And then he just got worse. He was sleepy. He was sort of, not waking up, just not being himself. This was more than a headache. So the next day he came in and he had a scan that looked like this. So this is a brain scan. This bright white is the bone, hazy gray is the brain. Then this circle is around this sort of starfish bright white pattern. So that's all blood. And that's blood in the pattern from an aneurysm rupture. So again, 22-year-olds don't come in with this, but he did. And he had an aneurysm. You can see it right there. Small, irregular, gnarly looking for people that do what I do. By the way, he knew he had polycystic kidney disease, and his dad and an uncle had all had aneurysms. He was only 22, but he had never been screened. We were able to treat this with the coils, kind of the heart cath catheter type way, and followed him for 2 years now, and he's done great. He made a full recovery. Is back in his military service, has actually been restationed to Texas, and we're working on getting him some follow-up there, because again, he is the exact person, right? He is not done with us. He is never done with us. He needs to continue to get screening for this aneurysm, making sure that doesn't change or need more treatment, and that any others don't develop, because He has polycystic kidney. He has family with it. He's personally had a rupture. He was only 22. I mean, this is someone that's never going to lose track of me or scans like this. So a happy story in the way that he made a great recovery, but they don't all end that way. So I'm sure Christine can talk to you about the patients that, you know, we fundraise on their behalf in their memory because they didn't know and this happened and they didn't make it. So we don't want that to happen to anybody. And just a couple of references. Happy to entertain any questions. Feel free to email anything else, questions if you're somewhere and you have, you know, who can I see? Who do you recommend? I'm happy to help connect you. The BAF is another obvious, amazing resource for aneurysms. That's my X handle if you want to continue the conversation. And thank you so much for your time. And let's share thoughts, discussions, questions that came up for anybody.
All right, excellent. Thank you, Dr. Kichelinski and Dr. Lipschitz. I have a couple questions in the chat and then some questions from when people registered. So I'll start with the ones in the chat now. It says, if you had an aneurysm erupt, what is the chance of getting PKD? And are there blood tests that indicate you're susceptible to PKD?
I feel like that's a Josh question.
Yeah, so that's really interesting. And Dr. Kichelinski I never thought about it, but to look the people who have aneurysms and rupture, how many of those have polycystic kidney disease who didn't know about it? So the only way you can get it is by genetics. You know, your mom or dad had the mutation in PKD1 or PKD2, and then half their kids have it. Although 5% are actually spontaneous mutations. So even if your parents don't have it, you can still get it. But it's not something you develop over time. You'll be born with that, but it doesn't always manifest till later in life. So the aneurysm could be the first, and going the opposite direction and seeing how many people with aneurysms have polycystic kidney disease is a great idea. And I hope Dr. Kichelinski keeps going with that idea for research.
Yeah, I know actually, I think at Beth Israel, the BAF funded some research where they were looking at exactly that number in the reverse direction, how many patients that come in with an aneurysm have kidney disease that kind of wasn't recognized previously. I think that number is probably pretty low because there's a lot of aneurysm patients and this is a niche part of it. You know,
but maybe I was going to say maybe the people like that 22-year-old,
right? Exactly.
Sometimes the cyst won't even show up on the kidney, you know, when they have polycystic kidney disease at that age because it takes time. What happens is it's a second hit. So you get a second mutation in your other normal gene, and those develop over time. And it's interesting, it's labeled a rare disease, polycystic kidney disease, but it's 500,000 Americans have it, 12 million people worldwide. So I guess it's a common rare disease, if you will. So.
Yeah, and so I would say, you know, when someone comes in, if you're 65, you smoke 2 packs a day, you know, like, and you have a ruptured aneurysm, it's not gonna, you're probably an unfortunate person with the run-of-the-mill type aneurysm. You know, I think when we have these unexpected cases, like where people are in their 30s, 40s, 20s, they come in with an aneurysm, they have multiple aneurysms at that age, they well out of proportion to their risk factors, like they don't smoke or they don't have hypertension. And they say they have multiple family members, then our bells start going off where, you know, you would want to screen people. You know, I would also say that all these factors absolutely work together. So if you know you have PKD, controlling your blood pressure, not smoking, like that is going to really, you know, these are all work together. And so you can't change your genes, but you can control some of those behaviors that are going to accelerate your risk and your risk of rupture and formation. And then maybe Dr. Lipschitz, can you speak at all to what screening you typically, like who would you see and suggest a screening for PKD, and what are the screening tests?
Sure. So, and I'll just mention the hypertension too. That can often be the first sign because what the cysts do, they push on the kidney that releases something called renin. So it's a renin-mediated hypertension. So we specifically use antihypertensives, ACE inhibitors, and ARBs specifically to treat the hypertension. But the screening, there's well worked out. If you have a family history, your mom or dad had it, you can get an ultrasound as the screening. There are genetic tests you can do that aren't that expensive, but the ultrasound criteria are very good, and there's no danger of radiation with ultrasound or anything like that, and it's age-based. If you're over 30, then the ultrasounds are a really good screening tool.
Great. All right, so we'll move on to another question here in the chat. It says, someone said they had both a left MCA and right MCA clipped within 8 years, recently found cysts in their liver, spleen, and kidney. Would you classify that as PKD?
You'd have to find out how many cysts there are. Simple cysts, most people have, they're very common. But multiple cysts, dozens and hundreds of cysts, that's a different story. So I guess you'd have to see what the scans look like really. And then of course, family history and genetics, you could do genetics as well.
Okay, another one, thank you for that. Is PKD also associated with diverticulitis? I've had brain aneurysm eruption, 2 surgeries, diverticulosis. So should I test for PKD? I've had no family history for anything but diverticulitis.
So there is association, but the diverticulitis is also a common thing. But yeah, one simple thing would just be get a renal ultrasound, inexpensive and very safe.
Okay. Another PKD. I have PKD type 1 and 2. I had an aneurysm clipped at 18, unruptured, and then 27 years later had my second aneurysm unruptured, clipped. I was diagnosed with PKD at 8 years old. I also have splenic artery aneurysm. I get screened every 2 years, and I can only do CT with contrast and angiograms. I do not have high blood pressure, just very aneurysm prone. I have 4 children. What age and what would you screen for first?
So yeah, I have had patients, very similar to Dr. Kichelinski, where they're 18 years old and they have a ruptured aneurysm. So I would screen early, 18 years old, with an MRA. Some people don't want to get screening because they're worried about, so with the Affordable Care Act, you can't discriminate based on, existing conditions, at least right now, but still disability and life insurance, they can be discriminated against. So at least, measure the blood pressure. If the blood pressure's up, then you definitely want to treat the blood pressure and also worry about polycystic kidney disease. But with that kind of history, I would recommend at 18, an MRA, or maybe, what do you think?
Yeah, I would say an MRA at age 18, and probably maximum every 5 years. You could even do the KDIGO recommendations even say like annually every 1 to 3 years sometimes. I mean, I think 5 years, they develop fairly slowly. So 5 years should be a reasonable interval, in my opinion.
All right, thank you. Someone says that where they feel they have to be their own advocate in regards to PKD and anything related to it, and wants to know if there's a specific website or foundation that they can go to regularly to find more solid information that will help educate them, and they can bring it to their doctor's office. So I think we know that there's a National Kidney Foundation, the Polycystic Kidney Disease Foundation,
Yeah,
that I think has great information for anybody wherever they are.
the PKD Foundation is a great organization. It's patient run, and if you want to get a little more into the weeds, that the KDIGO recommendations, they did a new one that came out in February of 2025, and they have summaries of it, which are pretty nice. There's center of excellences all around the country now, so wherever you are, there's probably one within a reasonable distance.
Okay, thank you for that. Is there any relation with fibromuscular dysplasia to these diseases that we're discussing?
Yeah, no, that's a renal vascular disease that's very separate from polycystic kidney disease.
And it's interesting. I was just thinking about this from an aneurysm perspective, because I had a patient who had not polycystic kidney, but a family history, who we treated yesterday. And she said, "Oh, my niece has something. Look at this report," because I had recommended family history screening for them. and her niece has fibromuscular dysplasia, which is this sort of vascular abnormality. It's a little bit of a no man's land as far as brain health goes. I mean, we know those patients have weaker vessels. They do develop aneurysms at a higher rate, and they have also dissections, another injury you can have to the vessel wall, at a higher rate than the average. But we don't really know much more about it from, at least from my perspective, as far as like preventative things to do or different things. It's just sort of being aware of your risk. There's not a guideline to necessarily screen those patients for aneurysms, but we do know there is some overlap for those conditions, and there is overlap with fibromuscular dysplasia in the carotid arteries and head vessels, and also the renal arteries, right, Dr. Olivia?
Yeah.
So it can exist in multiple places, but sort of another finding that maybe doesn't have a complete home. It has manifestations in lots of places, and nothing preventative, but it can have associations with other issues, but not PKD.
Excellent, thank you. Is there a relationship with peripheral vascular disease? And also, is it normal to have 1 or 2 cysts on liver or kidney? This is someone who's had a brain aneurysm.
Yeah, it's very common to have what they call simple cysts. You want to make sure they're simple cysts, which means there's just one color, one echo pattern in the cyst, that it's not, they can be complicated. So they can, if they have calcifications, we worry more about cancer, and there's a Bosniak scoring system for the cysts. But cysts are very common in the liver and kidney, 1 or 2. We see it all the time.
Excellent, thanks. Someone said their nephrologist ordered their MRI, and they had it done in June. They had it done without contrast, and there was no aneurysm. What is the difference between an MRI and an MRA?
Great question. So an MRI and MRA are both images that are obtained with the aid of magnets to visualize different tissues in the body. The MRA is a specific protocol that targets the vessels. So it's going to show you what the vessels look like specifically. An aneurysm could be detected on an MRI, but it absolutely could be missed as well. A generic brain MRI is not designed for finding vessel abnormalities. It definitely has, especially if they're larger, but not a small one could if you have not had dedicated imaging of the vessel, you could absolutely miss it. So we would recommend an MR angiogram. So that is a specific way they format and complete the test that shows you the vessels in isolation and not just the brain itself. So if you just go back to your MyChart or your reports, you can see if it's an MRA. I don't know if your nephrologist ordered it, they probably knew the right thing. But if it's an MR angiogram or MRA, that's what you really need, because again, we know in PKD they can be small aneurysms, so you really need the dedicated imaging, because the MRI could give you a false sense of security if it was not the appropriate imaging. And an MRA can be completed with contrast, but you don't need contrast. You could still detect things without contrast.
Yeah, and I'll just add one thing. There's only one drug that's approved to treat polycystic kidney disease, and the best marker for who we treat, because we only want to treat the rapid progressors, because it has some side effects. It's only moderately effective, but we need to know the kidney volume, the total kidney volume. So all patients that come to see me in the polycystic kidney disease clinic, we get both an MRI of the kidneys to calculate the total kidney volume without contrast, and an MRA at the same time to look for aneurysms. And I always try and get these tests at the same time, because they're in the scanner already, and it doesn't make sense to have someone come back twice. And they're both without contrast, which is nice.
Excellent. Here's a question someone submitted. If someone dies of a brain aneurysm, has relatives with PKD, does that mean the person necessarily had PKD as well, or no?
Yeah, it could be. It's it's half the family members. You definitely want to see which side of the family it came from, but the big thing, the important thing also to know is that, like Dr. Kichelinski was saying, that if you have a family history plus polycystic kidney disease, your risk of an aneurysm goes from 12% to 17%. So that's a big jump. But we're screening everyone with polycystic kidney disease. So all family members with polycystic kidney disease should be screened.
Great. Someone wants to know, is there a relationship with brain aneurysm and polycystic liver disease? You mentioned the specific test for PKD already. So are there any differences of tests depending on someone's ethnicity?
Yes, so it's one of those where it's spread out. It's an There's no discrimination. It's to everybody. And it's interesting because it's a second hit in the normal gene. So as the cells divide, it's almost impossible to get two. The body's very good. You don't get two what we call somatic mutations in the same gene in both your mom and dad in the same gene. But if you're already down one, then you get it. The chance of a second one is relatively high, but you have to collect those over many years. So you go into kidney failure in your 40s, 50s, 60s when you've already had all your kids. So it's some diseases like cystic fibrosis, they used to not be able to survive. But in polycystic kidney disease, it's a very ancient mutation, and it's in all populations, all ethnicities, about the same 1 in 400 to 1 in 1,000.
Okay, thank you. Someone also wants to know, are there other diseases that can cause genetic brain aneurysms? There's someone that has there are 5 boys in the family, and 2 of them have brain aneurysms, but nobody has kidney disease.
Yes, absolutely. I see lots of patients that have family history of aneurysms, but not polycystic kidney disease. So you can absolutely have that. There are some other genetic conditions that we do know about, like Ehlers-Danlos. There's some other systemic illnesses that people could have that could be connective tissue things that make their vessels weak throughout their body. There's also a definite link that we don't understand. Like we know we see it in the families. The current recommendations are more than 2 first-degree family members. If you have 2 first-degree family members, then you should screen other people that are related to those people. I'm pretty loose with that in my own practice, just because I'm biased. I see all the people that don't do well after a rupture. So I count a grandma in that, or an aunt and uncle, even though it's not technically a first degree. So we definitely see this happen in families, and there's a lot of work going on, BAF supported and otherwise, about the genetics and what are those genes that we're seeing that are definitely happening with sort of in isolation with just brain aneurysms. They're not all worked out. So it very well could be that you have a predisposition in your family to develop brain aneurysms, but you don't have polycystic kidney disease. And that is sort of an unknown entity at the moment, but something that absolutely those other people in your family should be getting screening with MRA as well.
Great, thanks. Someone's asking about what's the life expectancy of a patient diagnosed with both brain aneurysms and polycystic kidney disease?
Well, it also depends a little bit on the mutation in the gene. If the mutation is what we call a truncating mutation, where it doesn't make any of the protein, they tend to have worse outcomes. But the kidney failure, usually around 40, 50, 60, it's the 4th leading cause of kidney failure. But we can transplant patients, do dialysis. So the lifespan shouldn't be shortened significantly, assuming that proper treatment's done, aneurysms are found.
Yes.
Okay, thank you.
And
go ahead.
An unruptured aneurysm, we typically don't think of as shortening your lifespan necessarily. I mean, there's a risk of rupture, but for most patients that don't have polycystic kidney, that's on the order of like 1 to 2% in 5 to 10 years. So, and often we can treat these with pretty low risk. As treatments get better and safer, we can be more aggressive in who we treat, because that balance of the risk from treatment and the risk of the natural history of leaving it alone starts to tip a little bit. So a rupture definitely can shorten your lifespan, but just finding an aneurysm, we don't typically think of that as, taking, quote unquote, taking years off your life necessarily, or limiting your life, especially with the treatments that we have available right now.
Thank you. Are PKD patients still at risk for an aneurysm after kidney transplant and both native kidneys have been removed? And then someone did ask prior, when you have kidney transplants, do they always remove the native kidneys?
So most of the time they actually don't remove the native kidneys, because what happens is they get very large. They can be 100 times normal size, and there's all kinds of adhesions. And the transplanted kidneys put in the pelvis. So it's not in the not in the back, the retroperitoneum is what we call it. But if you're having a lot of pain, sometimes you do need to remove the kidneys, or if the kidneys are, really huge, there's just no room. But again, so you still have the abnormal gene mutation in other places in the body, so it doesn't protect you. And that was a really good point by Dr. Kicielinsky, that once you've had your transplant, you still need to get the MRAs and see, every 5 to 10 years.
Great, thanks. Here's a multifaceted question here. Someone's mom had a ruptured brain aneurysm, but has undergone the surgery, and she has some questions. She said, what are the chances of another aneurysm forming? Are there any specific lifestyle changes or precautions that you should take? What are the signs of potential complications or recurrence? And how can she manage stress and reduce the risk of future aneurysms?
Great questions. I'm looking at it so I can reference all of those.
Okay, good. Yeah.
Great points. So the risk of another one forming depends a little bit on the PKD. We talked about if you have an aneurysm and you have PKD, your chance in, I think it was 15 years of developing another is about 25%, which is pretty high as far as what we take care of. And if she is just sort of general population, someone who's had a ruptured aneurysm that's been treated but does not have that PKD piece of it, it's pretty low. Depending on her other lifestyle factors, it's probably only on the order of 1 or 2% in her lifetime. Anyone that has an aneurysm, for the most part, I graduate people when they reach age 80 or they're too sick to consider treatment, but I follow most patients sort of lifelong. They may get out to an every 5-year interval scan, but they're people I don't lose track of for the most part. Again, unless their other health problems become predominant, it wouldn't make sense to screen anymore. Lifestyle changes or precautions to take is definitely, keeping your blood. There's two things we talk about. Keeping your blood pressure in a good range. It doesn't have to be artificially low. You don't have to target some basement number because of the aneurysm. The same number your kidney doctor, your cardiac doctor, your heart doctor are looking at to keep you healthy is the same one that will keep your brain vessels healthy. So, less than 140 we typically talk about, and not smoking. So those are the things. People talk about vaping. I really don't know. The jury's out on that. We don't have enough data on that. I think it's probably, if I had to guess, it's slightly better than smoking, but not as good as abstaining completely. So how could you manage stress and reduce the risk of future aneurysms? Believe it or not, like stress or coffee or those things, other than their influence on your blood pressure, haven't been shown to be independent risk factors for aneurysm formation or rupture. So managing your stress as far as it influences your blood pressure and your quality of life is good. Specific to aneurysms, less of a clear link there. I think everyone's different in what helps them relieve stress. Also, I should mention, and BAF is great at this, support groups, understanding that like anxiety and depression after an aneurysm is incredibly common. You have faced your own mortality. You probably can't do all the things you used to be able to do. There's a facing your mortality. There's a loss of who you were as a person. You're a new person. Some of the patients that I think have the hardest times are the ones who do pretty well, actually, because people look at them and they remember them, how sick they were. And they say, you're a miracle. You look great. You're perfect. Like they can't see it. But the patient realizes that they're not doing the things they used to. They're not working the way they used to. They can't do complex tasks the way they used to. And there's a real loss and mourning of that, and a sort of an aloneness and feeling like other people or their family may not see that. So resources like the BAF that have support groups, people in the same room that are at different stages of recovery that can say, hey, I remember that, or hey, it will get better, or everyone feels this way. I think working with a counselor is really important if that's your style, because it is absolutely part of the disease. And the medications she's taking make her get kidney disease. There is none of the there's no, and Dr. Lipschitz can speak to this, there's no sort of medication that can induce kidney trouble. This polycystic kidney disease, that is a gene that you inherit. It is not sort of brought on by medications or other specifics. And the medications that we typically use in aneurysms are blood thinners sometimes, and those don't really have a link to kidney disorders. Anything Dr. Lipschitz wants to add that?
Yeah, the one thing that the latest KDIGO recommendations, So that blood pressure is really important. So if you're 18 to 49, we actually target less than 110 systolic. So that's a lot lower than most in the general population. If you're greater than 50, we target less than 120. So, and again, we'll use specific medications, ACEs and ARBs, but it's a lot more stringent than the general population, and our regular kidney population as well. So that's some.
Which is why stuff like this is so important, because I'm walking around telling people it doesn't have to be artificially low, right? And like the kidney doctor is telling me, yes, it does in this scenario. And what's amazing is those KDIGO recommendations, which are incredible and impressive, I had never heard of till I started talking to my partners across the hallway a few months ago. So again, the silos hurt us, and we're trying to help with that with things like tonight.
Awesome. Someone says that she and her sister both have PKD. The sister had an aneurysm rupture. So she wants to know, what questions should she be asking her primary care nephrologist? Because apparently she has not been screened for an aneurysm.
She should be screened. Yeah. And she should, I don't know how bad the polycystic kidney disease on the kidney, but I'm getting on everybody an MRA and an MRI at the same time. And you specifically have to ask the radiologist to get the total kidney volume. It's not that much. There's an app that they have to put on so it calculates it. They use this ellipsoid calculator. But anyway, so I would recommend that they do that. Because if they're what they call the Mayo Clinic has this calculator that goes from 1A to 1E, and you can find it on the web. And if you're 1C to E, that means you're a rapid progressor, and the risk and benefits would favor you being treated with tolvaptan, which is the only drug that's on the market that's been approved for treating ADPKD. And actually, it just went off patent a couple of last month. So there's some generics, although I'm not sure how that affects everything, but yeah.
And I would say definitely just tell them you need a brain MRA because you have a family history of PKD and aneurysm rupture. And if your insurance gives you pushback, they should not, because I mean, this is like guideline. You see that thing I put in there, that guideline level evidence that it is recommended for screening. So you should be screened now and probably every 5 years.
No, that is great information. I know just with aneurysms, the screening is very tough, with that basic rule of thumb, that it's 2 or more family members, but, it takes time. Sometimes someone finds out that second family member, where if they had had a scan, they could have been treated before rupture. So it is a hairy thing. So it's good there is more of a definitive guideline with the PKD and the aneurysms. I think that's great.
And definitely research, again, BAF supported and correlated about like, okay, if all comers don't need to be screened, are there subsets of people that should get screening, even if they don't have a family history? So, women 40 to 60 who smoke and have high blood pressure, like these people that have an overrepresentation of aneurysms, doesn't make sense to screen those. We have not gotten to the point of evidence that says that's the right thing to do right now, but we are actively trying to figure that out.
Yeah, oh, that's great. Someone you see, has had PKD for many years and had a brain aneurysm unruptured. Both kidneys are almost completely covered with cysts, but both are functioning perfectly. What are the odds my kidneys will eventually stop functioning normally?
Yeah, so the funny thing is that the kidneys can be full of cysts, and you're still clearing the waste products. So the best actually biomarker is really this total kidney volume, as opposed to measuring the creatinine or the glomerular filtration rate, which we do in different conditions like diabetes or hypertension-induced CKD. So you just have to you can plot it out over time or use this calculator. But if you have a mutation that's not truncating, meaning that there's still some of the protein being made, as we call missense mutation, then it's not as bad as a truncating mutation. And many people will die with the polycystic kidney disease as opposed to of it. So sometimes it doesn't even cause kidney failure, which would be great. And those are what we call the Mayo Clinic calculator 1A and B, and those are the people we shouldn't treat with this drug tolvaptan. So hopefully you're one of those 1A, 1B people.
And Dr. Lipschitz, I think I saw in the chat, someone had asked, sometimes people have aneurysm clips that they don't know the identity of and they're not MRI compatible. So how could someone, are there alternative tests where they could get the kidney volume for the medication candidacy if they can't get an MRI?
Is that a thing? I thought they were all like titanium based.
Yeah, I mean, they are. There's nothing in sort of the modern era that's not compatible, but typically if you don't have the identity of the actual clip, the MRI technicians and the radiology policy is not to scan.
Okay.
And often those records are lost or missing. It's happened in our own patients. So I'm really vigilant about now putting the identity of the clip in the op note, because that is something that usually will be retained even if the records from the case are not. So yes, there are definitely patients that don't know the name and can't get it.
Yeah, CT CT would be fine too.
Okay.
The only thing you get the radiation with the CT.
Okay.
But
It would still be a way to screen and determine candidacy.
Yeah, definitely.
Great.
All right, well, we are coming up on the hour. I just want to ask the doctors, is there anything, just you want to close with about the importance, I just think, of overall awareness, education, and screening for these diseases?
I think everybody with polycystic kidney disease should get screened for an aneurysms, as well as getting the MRI for the calculation of total kidney volume, and do them at the same time. So it would be much easier for everybody, for the patients. And I actually had a question for Dr. Kicieliński. So if this is the size of an aneurysm, whether you can follow it or you have to treat it, do you use a smaller size of the aneurysm for PKD patients, or is it the same size?
Yeah, it's a little, because there is some data that smaller PKD can rupture even at a smaller size. We're a little more aggressive in those patients. Not saying everyone gets treated every time, but we definitely, that comes in the conversation. Again, it's kind of managing the risk and the benefit. If we feel like we can treat it with an acceptably low risk, and it's, the method to treat it, it doesn't expose them to excessive harm, we usually try to get those fixed if we can. So size is one factor that influences rupture, but it's not the only one. And definitely location matters. There are other comorbidities, and family history and PKD definitely play into that. And then there was this one question that people are asking about it, how often should you be screened? And I would say, if you had an aneurysm and you've been treated, 5 years is the max. You could do it as frequently as I would not do it any more frequently than a year. Annually is the absolute, probably the lowest I would go, anywhere from 1, 3, or 5 years, depending on how, I stretch it out over time. If we have several scans on the chart that say that there is nothing, then you can start to spread it out more with more confidence. Maybe those first few are closer together. And depending on your other risk factors as well, like if you also smoke or have hypertension, I would definitely keep a shorter leash on that. Again, 5 year would be probably the max, 1 year would be the minimum, and dealer's choice between that.
Excellent. Well, I want to thank both Dr. Lipschitz and Dr. Kicieliński very much again for taking the time to share this information. Both these diseases are very important. We can see they come together. Thank you to the National Kidney Foundation, the PKD Foundation, for the work that they do. But I think having these conversations, sharing this information is really critical to helping people down the road to better understand, to save lives, keep families together. That's what we're all trying to do. So thanks everybody who joined. It's a good wrap up to Brain Aneurysm Awareness Month. And for the doctors, do you have an email you would want to share if anybody wants to reach out with further questions? You can just throw those in the chat.
Yeah.
Oh, you're welcome.
Thank you again.
Good question.
This is a lot of fun. Thank you.
Thanks, everybody.
All right. Thanks, everyone. Have a great night. Take care.
You too. Bye.
Bye-bye.